Well, thank you, Megan. And thanks to Connexus SG for facilitating today. We really appreciate it. So good afternoon, or yes, still afternoon, just barely, for everybody. Welcome. Thanks for joining us today. And I'm going to introduce our speaker, Brian Fortune. One last comment before we do that is if you have questions, please use the chat. That will be down at the bottom of your screen. And I will monitor the chat. And if we have questions for Brian, we'll introduce. So with that, let me introduce our speaker, Brian Fortune. He's a founder of Farragut Square Group, which recently became a part of the consulting arm of McDermott, Will, and Emery, the big law firm. Farragut advises institutional investors and private companies on strategy and due diligence and transactions on really the future of federal and state legislation, regulatory matters, and so forth in healthcare, obviously. Interesting, my employer recently engaged Farragut Square to do an analysis on Medicare and commercial payer, really the current status and the outlook for 2022 and beyond. And with all that is going on right now in healthcare, it was very good to learn about what Farragut Square sees now and in the near future. A little bit about Brian. He is a founder of Farragut Square, and he is responsible for Farragut's research and all their diligence work. And before co-founding Farragut, he was a political strategist and managing director at the Marwood Group. He's a frequent speaker on healthcare policy, politics. If you've got his screen up, you'll see he's got the Capitol there right behind him. So he's all about the Hill. So much so that before Marwood Group, he served Republican leadership in the U.S. House. He worked with Speaker John Boehner, familiar name, Majority Leader Dick Armey, even more familiar for us here in the Dallas-Fort Worth area. And Brian worked on a number of major initiatives, particularly Medicare and Medicaid. A little personal about Brian, he's a graduate of Oregon State University. And so I'm sure with the rivalry with Oregon and the previously called Civil War, it was probably one of his first exposures to politics. But we really would like to thank Brian and welcome Brian. So Brian, take it away.
Thank you, Steve. That was great. I will tell you that Oregon State, when I was there, had a just horrible football team, but they could always be counted on to show up for that Civil War game. So many seasons, they would go 0-10, but somehow win against the Ducks. So yes, that's actually one of the more interesting games during the regular college season. So I'm going to share screen now and press that magic button. Thanks, Megan. All right, so our task today for the next about 50 minutes is we're going to kind of walk through 2021 healthcare trends and activity. As our moderator said, what my team does at Farragut Square Group is we kind of walk through where things are in the healthcare reimbursement and regulatory landscape, and then we project that forward 3 to 5 years. All of us come from various policy and even political or policy backgrounds, but our job really isn't to tell people how the world should be. All of our clients are more interested in how the world actually is and where it's going. So, we're pretty, even though we all have our own fun partisan feelings, we're pretty heavily nonpartisan when it comes to ideas. So what we're going to walk through right now is current state of play on where the administration and Congress are going on the subject of healthcare policy. We're going to kind of roll through that into a lot of healthcare trends. So, we're going to talk about Washington a little bit up front, and we may well talk about Washington in the Q&A because Washington's always fascinating to either a comical or tragic degree. And, then we're going to move on to the real world, what's actually been going on and on the line in the healthcare provider universe through COVID and beyond. I'm going to talk a little bit about, we advise on a lot of healthcare M&A activity and mergers big mergers between health systems and whatnot. So we're going to talk a little bit about healthcare deal trends that we've been seeing. And then, of course, we spend as much time with our clients talking about what commercial managed care is doing as much as all of the governmental payers, because in many cases, the healthcare system is overwhelmingly affected in almost every level by what the commercial payers are up to. So with that, let's dive in. All right, important table setting. Anytime I give a speech, I try to tell you, in addition to what Washington is trying to do, I think it's really important to examine the context with how they're trying to do it, or the current state of power in the city. So what we're going to do right now is contrast as you know, in the last election, particularly after the runoff elections in Georgia, the Democrats woke up and realized that they were in full command of all of the policy branches of government. They controlled the House and the Senate and the White House. And of course, from that flowed a lot of big ambitions. President Biden was going to be the next FDR or LBJ and, do amazing, I think the progressive term is transformative things. However, let's compare that with 2009. The last time we saw that happen was, in the 2008 election, President Obama got elected. He got elected by a healthy margin, and he built on big Democratic gains in the previous off-year election, and they had pretty large command and control of the city. So you see in the 111th House, which was the House in 2009 when President Obama first took office, they had 257 Democrats. So you can see that little blue line, that is way larger than the 218 you need for a majority. Well, let's look at what we have right now. There are 220 Democrats who are currently sitting to 212 Republicans. There are 3 vacant seats that haven't been filled right now. But again, 218 for majority. So sometimes you may see this reported. In order to get anything through the House, Speaker Nancy Pelosi can lose no more than 3 votes. She loses 3 votes of her own members. They can't move anything through the House. Let's go to the Senate. So again, when President Obama took office, the Democrats had 60 seats. So that's 59 actual Democrats plus 1 independent who caucuses with the Democrats. That is a filibuster-proof majority. So in the, if you remember, in the U.S. Senate, they have a tradition called the filibuster, and it allows you to, effectively endlessly debate a piece of legislation, but you can shut it down if you get 60 members to vote to limit debate or bring it to a close and move on. So, sometimes in the paper you might read about things called cloture votes, where they're trying to bring 60 votes and shut people off. Now let's look. After winning the 2 Georgia seats, Democrats have exactly 50 seats. So they do control the chamber, but they only control the chamber because in the instance of a tie, the vice president will preside over the Senate and supply the tie-breaking vote. So bottom line is, what we're looking at are the most paper-thin, super razor's edge margins that we have seen in a long time. I think it was, I think I'd read somewhere the House has the narrowest majority that they've had, since the early 20th century. Let's go back to those big ambitions. So this year, has been dominated by three themes. The first one was pretty much a guarantee. Back in Q1 and in the early months of the year, Congress needed to debate another piece of COVID relief legislation. So they passed about $1 trillion in change in additional COVID relief that kind of built on the CARES Act and a number of pieces of legislation, probably about 5 in total, that they had done in 2020. But they were well underway on deck to do another one in Q1, and so they did that. Then they settled back into kind of the next big projects for the year, and there are two. So the first one, which the president just signed in the last couple of days, was a large $1.2 trillion infrastructure bill. That's mostly about roads, bridges, a little bit of green energy. There's many other cats and dogs in there, but still, for the most part, this is primarily an infrastructure bill. It does have a few healthcare provisions in it, though. So a lot of healthcare providers back in 2020 got a little reprieve because there was something on the books called the Medicare sequester, you may know about, which was essentially a 2% tax on claims. My hospital friends back when Congress actually created it were like, oh, it's like just a short-term one-time thing. And I said, that's a permanent 2% market basket cut. And that's pretty much what it became. It's a 2% back-ended tax on claims. They suspended it during COVID, and they continued to suspend it for kind of the duration of the public health emergency. However, it is scheduled to kick back in next January. So January of 2022, the 2% sequester will come back into force. And to reinforce kind of where Congress is on the subject of the sequester, one of the offsets in the infrastructure bill, or BIF, lovingly named BIF that we call it, they would extend the life of the sequester out another year. So they're not only assuming that it's coming back into force, but they're going to keep rolling it out into the far future. If you're in the PBM world, they also delayed the implementation of a very controversial rule from the Trump administration, which would require all of the PBMs that participate in the Medicare Part D program to end getting any types of drug rebates that they get based on, their prowess at negotiating deals or steering drugs for one brand to another in the generic world. The Biden administration had already delayed this rule. We had expected that rule might would very likely fall on its merits in a court challenge. But the Biden administration, when they first came in, the first thing they did was delay it by 2 years. And they did so deliberately because, unlike most regulations, a lot of controversial regulations that Congress does actually would propose to save money out of the Medicare program. This one was very unique in that even the White House Budget Office or the CMS actuaries, they didn't believe it would save any money. They actually believed it would cost a few $100 billion over 10 years, so it wasn't saving the program money. That becomes, not to delve into the realm of budget gimmicks or games that we play, but whenever there's something sitting out there that's actually going to, cost a lot of money, if Congress sweeps in and repeals it, they basically capture a bunch of savings. And so that's why they delayed the rule. They knew that Congress would probably be interested in kind of grabbing it as what we might call a free, put it in quotes, a free offset to help offset some other spending. And then there's some smaller provisions, regarding drug manufacturers and that. All right, now there's the second one. So the BIF has now been signed into law. That happened, a few days ago, and now people are talking about that, and the money's going to start flowing out the door. That leaves the second big project that congressional Democrats in the White House laid the table for to do, and that was what often is called they call it the Build Back Better Act. In modern press term, people just call it the reconciliation bill, or they may call it the social infrastructure or the social spending bill. It was originally conceived as a really big bill in the order of, $5 to $7 trillion. The Senate then kind of spearheaded the process by which Congress would consider it, and they reduced that amount to 3.5. And as I'm going to go through now, it has shrunk further. It's now 1.75, and it may shrink yet again. Let's see the top line ambitions. Obviously, the stuff in healthcare that everybody focused on was that, one, they would expand the Medicare fee-for-service benefit to include dental, vision, and hearing services. They also would tackle some issues involving drug pricing. Particularly, there's a grab bag of things that they would do, but the most controversial one that gets the most focus by particularly the pharmaceutical industry is that they would eliminate a provision in the original statute that created the Medicare Part D drug benefit. They would eliminate a provision that prohibits the HHS secretary from negotiating directly with manufacturers. So right now that is a delegated responsibility. The Medicare Part D plans who administer the program and sell it directly to the beneficiaries of it, they negotiate their own deals with the manufacturers, and that has worked out pretty well over the life of the program. But this would allow HHS, the secretary, to step in and directly negotiate with the manufacturers. And so we'll talk about that more in a little bit. They originally envisioned $400 billion in funds targeted to the states to expand the home and community-based services. So, home and community-based services obviously involves a lot of things like unskilled nursing care under Medicaid, or unskilled therapy or other visits in the home. Primarily, this is entirely about Medicaid, but they started out with $400 billion targeted for that. They also would expand the current Affordable Care Act subsidies. So back in Q1, when they did the second COVID bill, they actually eliminated an income limitation on ACA subsidy eligibility. So if you're a person who gets healthcare insurance through the ACA exchanges, you could get subsidies up to 400% of the federal poverty limit. What they did was eliminate that ceiling. So now anyone whose total healthcare premium expenses would exceed, I believe, 8% of their income, they would qualify for subsidies. They expanded that during the public health emergency, so they kind of expanded that for a couple more years. What this would do is kind of, their original ambition was to make that permanent. And obviously they would expand some of they're trying to find a way to expand Medicare in the 12 or 13 states that currently have not expanded Medicare under the ACA. So as you all remember, the Affordable Care Act, or Obamacare, as some people call it, that originally would have expanded Medicaid to everyone in every state to 138% of the federal poverty level. The Supreme Court overturned that section of the law and said that the way that they wrote it, they were effectively coercing states, so it became voluntary. So over time, obviously you had kind of what we refer to as blue states rush in and adopt the expansion. A number of Republican governor states didn't, and then over time you've had a handful go ahead and expand, either because party control in the state changed, or in the case of like Ohio and others, they just felt that the money was too good to not take. And then back to that rebate rule, this large reconciliation bill would repeal it permanently and get about $50 billion in budgetary savings for doing that. Let me having trouble getting my slide to advance, Megan, if you know what's going on.
Yeah.
Let me see if I can go.
You can close that poll.
There it is. Okay, sorry. That's probably because the poll question was open. All right, as I mentioned earlier, back to the beginning, Congress is trying to do really ambitious LBJ level transformative policy with paper-thin congressional majorities. So what you can see with this little graphic is that we've undergone a process that I will refer to as the incredible shrinking bill. So, again, back in the summer, we were talking about $3.5 trillion, which for the progressives was already a big walk back from ambitions for a $6 or $7 trillion bill. And over the course of the last several months till today, that those ambitions have kind of been funneled down and down and down until we get to the current price tag is 1.75 trillion. That is not an official price tag. That is kind of the price tag that they're currently negotiating off of. But I will caution that Congress lives and dies by something called the Congressional Budget Office. So every piece of legislation that Congress has crafted, if they're going to put it on the floor, they will submit it to CBO, and CBO will do their own economic scoring of it. CBO has not scored the version that the House is trying to pass. They plan to issue partial scores of different pieces of it in the coming days. But the thing about federal policy is that every little program you create or nix has what we call an interactive effect. So these programs all interact with each other. So CBO doesn't just score, a new program by its own price tag. They also score it in the context of how does it affect spending in other programs? Does it reduce spending there, or does it increase spending elsewhere down the line? So, what a lot of people who want a CBO score are doing is they're holding out. They want to get this kind of vaunted interaction score that will kind of tell them what CBO's take is on the entire concept. So if you follow these headlines, you'll notice that the House has set deadlines by which they wanted to pass this $1.75 trillion bill. So they've actually had 4 of those, including one last week, and they've blown through all of them because a handful of their centrist members are holding out. They're saying, we don't want to vote on this until we see how much it's going to cost based on the CBO score. And so Congress is out for a week. They went, many of them went in a delegation over to Scotland because there's the climate conference going on, COP21. And they wanted to go pay a visit to that. And then the week after this week, when they come back, they're going to try to pick up where they left off. So back to the incredible shrinking bill. The original priorities in this from the summer of 2020, I remember the President Biden and Bernie Sanders, the senator from Vermont, came out with something called a unity agenda heading into the Democratic convention. And progressives played a very big role in writing up the unity agenda. So it was very, very ambitious. So it did not include Medicare for all. That was kind of the first concession. Progressives are very keen on a single payer healthcare system. They have never been able to achieve that dream because if you count the numbers, progressives are very strong within the Democratic Party, but not so much in the House overall. There is on any given day about 100 of them, give or take a few. So I believe right now the Progressive Caucus is about 95 members. And that pretty much tells you what your high watermark is for Medicare for all without even taking into account the Senate. So, in past years, like 2009, when I had clients who were really afraid that Medicare for all or single payer was right there knocking on the door about ready to come in, and they would ask me if it could possibly survive in the Senate, I would say, well, you don't need to worry about the Senate because it can't even survive a vote in the House, and it has to start there. So they moved on to the idea of a public option. So instead of Medicare for all, you would just have a government-run health insurance plan that would be part of the ACA exchanges. And, the progressive idea behind that is that, it would be cheaper and better, and it would undercut all the other plans, and eventually everybody would want to be on it. That's also deeply controversial because if you're an insurer or a provider, hospitals, physicians, and everyone else, you generally see the public option as what the progressive claim it is, which is a nose under the tent to kind of try to, angle for Medicare for all one day. So that also is deeply vote challenged. So that is not in the current discussion in any real form. Obviously, there we talked about drug pricing. They wanted to have a very aggressive format for HHS negotiating pricing. And in earlier versions that they could considered, they even wanted HHS to use international pricing to guide how they would set prices for US drugs. That is also not in the bill because, again, does not have the votes. And then we also wanted to have broad negotiation in the Medicare Part D program, and that has also fallen by the wayside. So, again, whether you're talking about expanding Medicaid or doing aggressive policies on drug pricing or trying for public options or kind of the big price tags on long-term care, pretty much each time they've had to kind of recalibrate their ambitions and sort of run it, through the reality of what they might be able to accomplish. Let me go back to this for a second. So on Medicaid, just going to update you for where they are. The original idea on Medicaid, of course, is that they would provide some mechanism for all of the beneficiaries and red states to get enrolled in Medicaid. So people who, in many cases, fall between like 100% to 138% of federal poverty, they would find a way to enroll them. Here's what they have. For 3 years, you would be able to, if you're one of those beneficiaries who currently would qualify for Medicaid if you lived in, say, California, but instead you live in Florida and you don't, you would qualify for enhanced subsidies to sign up for healthcare insurance through the ACA exchanges. So, right now the bill just has a 3-year eligibility for those subsidies and then nothing. So, the idea is, there are many policies in this bill that are getting a lot of controversy flaring up around them, mainly because they're being charged with being temporary. So, in order to keep the total cost of the bill down, they'll say, okay, we're going to do a policy for maybe 1 or 2 years. So same thing, Medicare coverage for dental, hearing, and vision. It's not in there. There's coverage for hearing aids right now, and that's it. So, they'll continue to debate whether they could find a way to add those. But again, it's trying, they're jettisoning things to keep this price tag down at 1.75 trillion in the hopes to keep other people on board. On drug pricing, they've also limited their ambitions. They have a few policies that I think are in the realm of, in the continuum of controversy, they're much more on the lower end of them. So, things like inflationary caps on Medicare drug price increases coupled with kind of a rebate to the government requirement. They've done some reforms to the Part D program that really involve the private sponsors more actively managing the cost of certain new specialty drugs. And then, they still have this idea of some negotiations, but they've limited their ambitions down to like 10 or even 20 drugs over the next 10 years. And they've narrowed it down to, only drugs that are single source drugs that, have been beyond their exclusivity period, and yet they're still monopolistic drugs on the market after, 9 or 12 years. Even that may prove to be too controversial to survive. So we're in for a very interesting mad rush to Thanksgiving and maybe beyond into December. I'm going to try to advance the slides. Can I do that, Megan?
Go ahead and close that polling question with the X, Brian, and you should be able to, yes.
Thank you so much. Nope, not yet. There we go. Look at that. All right. Now, listen, when we get to Q&A, we can go back to Washington and we can talk ourselves silly on DC if people want. But we're going to move on to kind of outside the Beltway bubble into the real world for a little bit. So healthcare trends that we have noticed in the last few years. One is there's been a lot of deals on healthcare IT. However, it's changed a little bit. So, if you look at over the last decade, a lot of the deals that we did and this goes back actually to the early Obama administration with the passage of the stimulus bill. They basically required all Medicare providers to shift their records to digital. And, we thought that was going to be a pretty tectonic move at the time. And not surprisingly, it did spur a lot of activity because, a lot of particularly doc offices were still on, totally paper records. So, there were incentives for people to switch over, but what you've seen is a lot of IT dollar flows have really been about the back office for the last many, many years. That's starting to change though. So, now what we're seeing is a lot of investment kind of beyond the back office things. And, you're kind of seeing a lot of healthcare IT in the realm of, I think it's fair to call it consumer directed care, because, a lot of it is now developing more things like, apps and, apps and device-based technologies to really create a better interaction between the patient and their data and the provider. And, I think that's an amazing development, and it's, it has a long ways to go. So I think we're going to see heavy activity in that space. But, I think it's fair to say that although we still see people investing in, kind of back-end tools and other things that kind of help them manage their own data, or, manage metadata, or even, incorporate some AI into that. The new realm of things are, I think, probably fair to say, a little more consumer facing in terms of much more interactive with the patient. Let's talk about telemed. 2020, every one of my clients would call us and they'd be like, tell me about telemedicine. And it always involved a very interesting, nuanced conversation because, as you can see, Medicare in the depths of COVID was very flexible with a lot of its regulations. Let me back up a step further. By law, Medicare's ability to pay for a lot of telehealth is very limited. It's only allowed in certain types of situations. So, the agency can't just use their own regulatory judgment and expand it willy-nilly. They have to have kind of a ironclad reason that won't get pushed back from Congress or get sued by providers. But they were able to use kind of the public health emergency and some authority that Congress gave them to really expand a lot of areas where you could use telehealth visits essentially on a temporary basis. And so we saw, you saw the humongous spike in telemed visits across a lot of different provider settings, as you headed through 2020. But, as people started to get vaccinated, or as the vaccines started to get developed, and you started to see kind of caseloads go down for a while, you saw that taper off and come back down. So now what we see is more of a patchwork. So, a lot of specialties were more than happy to use telehealth capabilities to stay up on patients. They needed to see them, so they found a way. But a lot of specialties very much wanted their patients, as you headed into this year, to get back into the office as soon as they were vaccinated and it was feasible. And so, not surprisingly, you've kind of seen the volume come down and taper off. However, it hasn't, it obviously, I think, will continue at this elevated level. That's because there were some healthcare areas where, we've seen that it actually adapted really well to it. So I'll highlight one: behavioral. Behavioral is kind of well suited for telehealth. So whether we're, looking at companies that do autism, they treat children with autism, or even adults with autism, or they're doing like intensive outpatient behavioral treatment or other things, substance abuse. Now, a lot of these things in the behavioral universe, it's extremely important, things like adherence to medication or regular therapy are an important part of the course of care. So, if the difference between telehealth and no telehealth is, patients just missing a meeting altogether, everyone realizes that, having that connection is the more important thing. So, in places like autism providers, we see them, they'll start off with in-person a lot of in-person visits to get the patient kind of comfortable with the setting and the provider and the physician, and then they will switch to a tablet or a telehealth visit. So a lot of this increased volume really accounts for areas where it just made a lot of sense in tying into the course of care. So value-based care, we talk a lot about value-based care. It is a happy buzzword in DC, and when you try to pin somebody down on what it means, that's when the conversation becomes, I think, fascinating and interesting, because it is a giant catch-all term. And what I often warn people about is that as far as CMS, the agency that runs Medicare, is concerned, value-based care many, many times is, can we design a new way of paying somebody for something that results in the same level of care or better and pay them less to do it? So, that is the agency's view of the world. They may put a lot of flowery and fluffy language around it, but if you actually look at the design of these care models, that's it in a nutshell. Can we get you to do the same or better care and pay less to do it? Which shouldn't be surprising. That's what value-based service means if you're, say, Walmart or in the retail business. Can I give you the same goods and services and roll back prices on it? But from each administration, you get kind of a change in focus. So with the Trump administration, and particularly with the CMS administrator, Seema Verma, she was very interested in more skin in the game. So what she was trying to do was stop what we'll call kind of the happy value-based demonstrations, where the early versions of like ACOs, Pioneer model ACOs, and some of the other ones was it's a one-sided upside demo. We'll give you a bunch of metrics, and if you hit those metrics, you can share in the savings that are generated by hitting those metrics. Verma very much wanted to move to two-sided models. So she flat out announced that future models coming out of the CMS Innovation Center for demonstrations and pilots would have more risk. So, you could make some money if you hit some metrics, hit some targets, but if you weren't hitting the targets, you could also lose money. As you imagine, provider sphere was not happy with that type of proposal. But then President Biden won, and President Biden, in putting the new command in there, not surprisingly, they changed up kind of the focus of CMMI a little bit. And, now what they're focusing on is they're trying to focus on kind of broad, multi-silo demonstrations. They haven't put any out yet, mind you, but they're trying to move away from the more risk model. And, I'll tell you what they're presumably angling in on. There are some demos that are very, very large that have really high participation. One of them is called the BPCI, or the Bundled Payment Care Initiative. That one kind of hubs around, a central group like, say, a health system or a large physician group, or some collection of providers in league with each other, and then they essentially have what was best described maybe as a proto-capitated rate per patient, and they have to manage from surgery through post-acute recovery, and then any downstream needs like, say, follow-up rehab and home visits. And that's a model that actually CMS can brag about, because it has really high participation, and in studying it, there's no question that it has saved a lot of meaningful money. They're not there yet. The other thing that comes out of CMS right now is that they're looking at more mandatory participation demos, and I think it's fair to say that mandatory demos run into potential problems. Even going back to the Obama administration and to the Trump administration, now into the Biden administration, mandatory participation demos tend to fall afoul of either politics or the court system, because when you force everybody into it, it's hard to say that it's a demonstration anymore. It's usually it's so big and everyone's in, that, the view of both Congress and the courts is this is no longer a mandatory, this is not a demo, it's not a pilot. You're actually trying to change policy. And, from Congress's standpoint, they're like, well, we're the ones who change policy, not you guys. So, that's our call. But bottom line, we're going to see a lot more demonstration models come out. And, kind of the new direction is that there won't be as much downside risk in the game. But, you're probably going to see some pilots come out that look controversial from the standpoint of mandatory participation. Last point on this, if you remember, once upon a time, there was this thing called the doc fix. Medicare had a formula by which doctors would get their Medicare rates updated each year. The formula had any number of flaws in it that I won't go through on this call. But it created this situation where, there was this huge cliff. Like if Congress just let the formula run, doctors would take, in any given year, like these escalating cuts that were like 20 to 35%, which of course is politically impalatable and wouldn't survive. So Congress a few years ago passed MACRA. MACRA eliminated that old formula and, basically froze doctors for 5 years. But as part of that, they kind of presumed that they would move to something called alternative payment models, or APMs. And what that meant was, they expected that the Innovation Center would run a lot of pilots by specialty. But current administration isn't really interested in that. As you can see, this is a quote. They're saying they're moving away from having a model for every specialty group. So that's interesting, because obviously, the sort of abstract future CMS wanted to move to was that, doctors would have a much more specialty specific type of payment arrangements. And, they're not planning on testing any of those in the near term. There we go. I mentioned this a little bit before. Another big trend, obviously, is we're going to see a continued conversation and more investment in the area of substance abuse. So, back in the 2015 to 19 years before COVID, you saw a big rise in the number of people who were addicted to opioids. Part of that was just, obviously people had access to a lot of new opioid derivatives, and they're potentially highly addictive. So Congress moved and invested quite a bit of money in focusing on that. So both federal and state took a lot of action in the realm of substance abuse. They made some meaningful progress on it, and then COVID hit. And when I'm in a live audience, I always ask everybody in the room, I'm like, can anyone who can say confidently that COVID and lockdowns has not affected your mental health, please raise your hand. And of course, nobody raises their hand. So, that's had an effect across the board, whether mild or major. The major is that, whereas the trend on overdoses and opioid addiction had been moving in a very positive direction, in 2020, it rocketed right back up. So, obviously Congress continues to appropriate money on it, but we're seeing a lot of private investment in kind of a new model of substance abuse. So, it's evolved a little bit. Once upon a time, substance abuse really was kind of one of two things. It was either a residential treatment facility, where you go and do kind of a 28-day inpatient program, or it was just, medical or prescription substitution. So MAT, you go like a methadone clinic. You're just basically getting a less addictive and less harmful drug to replace the one that you're addicted to, and then hopefully try to wean yourself off of it. It has evolved a lot in conjunction with managed care, which I think is fascinating in a good way. Now there's kind of a new model, and it spread out over the last 4 years, and managed care payers are interested in it. They prefer to contract with providers who have this kind of offering, and that is not long-term inpatient, but kind of short-term detox, there may be an inpatient behavioral hospital, followed by intensive outpatient therapy, and then combining that usually with some like substitution or MAT. And, you know, I think they're seeing good results on it. I mean, I'll caution that, you know, payers are always kind of looking at where the data is leading them. And, you know, it's still got a ways to go, but that's sort of the new model. And we're seeing, you know, kind of more of that as opposed to just kind of these sort of standalone bric-a-brac attempts. All right, we talked about drug pricing earlier and Congress's ambition to kind of rein that in from on high. But, you know, I often say to clients that Washington, if you want to know what's going on in healthcare, you can't go to Washington to figure it out. You got to go back to the state. You got to see what's going on at the local level, or even follow Medicaid. Washington tends to often and usually be fighting the last war, so they're late to the table in terms of recognizing a problem, and then it takes them forever to try to address it. And of course, then they try to impose, you know, kind of a national remedy for something that could be handled more chaotically at the local level. So let's look at drug pricing, and particularly the annual change in per cap inflation or drug spending. All right, so if you look at a couple of key points, obviously, as you see in the 90s, drug pricing per person went way up because you had a lot of what people refer to as kind of lifestyle drugs, a lot of new brands come out for allergies and for acid reflux and other things. And, you know, the culminating event on all of that was, you know, Congress enacted a Medicare prescription drug benefit. Since then, drug pricing per cap fell really steadily. And then, you know, back in the mid 2000s, you had some new drugs launched, some big breakthroughs that were very expensive. So if you remember a few years ago, we had several drugs come out that were curative for hepatitis C. You also had some new cancer treatments. Add it all up, and what you saw was the per cap inflation spiked way above 10%. In the 2013 and 14 period. It was also fed by another thing that happened, and that was in that same period, you had a lot of generic manufacturers consolidate. So obviously for small molecule drugs, generics are a really important thing, but when you have a lot of generic consolidation, what you saw generic prices going up, and you also had some generic drugs, you know, just nobody could make them profitably or they weren't desirable, so they just dropped them. So, you know, other people might come in and, you know, obviously they would try to offer them again at a much higher price. So the beginning of the conversation about prescription drugs really started in kind of about the 2015 period. And it originally started out as insurers warning Congress that the increase in generic price inflation was the cause of, you know, they were worried that it was going to hit Part D premiums. So, you know, again, it's taken, you know, that was an issue in the 2016 election. What's happened since then? Well, per cap inflation went negative even. It went all the way down, it went negative, and now it's kind of climbed back and is leveling off at kind of a, you know, somewhere around 5% or under. So, you know, what we have for the next 10 years is we have a whole wave of biosimilars that are now coming online. So you're seeing pricing pressure about to hit the last bastion of monopoly pricing, which are, you know, a lot of these biologics you would get in a physician office. And so, you know, my answer to all this is that market forces in the US still generally work and will continue to work, which is kind of why drug pricing debates in Washington have a big difficulty of achieving their goals. All right, let's talk about deal trends. So not surprisingly, there's a lot of private investment in healthcare, and that continued to rise all through the 2010s until you hit 2020. It was still healthy, but it dropped a lot. So that should not surprise anybody. there were lots and lots of physician specialty deals that were out there. And then in 2020 with, clampdowns on elective procedure volumes and everything else, people kind of hit the pause because they just weren't sure when that volume was going to come back. Fast forward to this year, this is a big year for healthcare transactions, and it is well on track to exceed the trends of 2018 and 2019. So again, this is a quick breakdown of kind of the areas that you see a lot of activity. As you can see, lots of things in the post-acute space are very, very popular right now because of the desire, both COVID related and just the general desire to keep moving things out of facilities and into the home or into an outpatient setting. And that will, I think, continue. Obviously, you've got a lot of investment dollars chasing a limited amount of assets. So, anybody who invests in healthcare would notice a little bit of frustration that they think the prices are pretty healthy and well expensive. So I have some lovely colleagues who spent their whole lives before they joined me working in the managed care industry and doing things like network design and contracting. And they always graciously fill me in on a lot of amazing managed care trends that we pass along to clients. And managed care primarily, if you want to get down to it, in a couple of areas, managed care works directly with the consumer, sort of like Medicare Advantage. So Medicare program, as you can see on the upper right, Medicare has a private insurance option called Medicare Advantage, and they offer services or bid against kind of fee-for-service benchmarks, county by county, and then they usually bid well under those benchmarks, and then they give back the bulk of that, sort of what they call a premium rebate, in the form of extra benefits. So right now, as it stands, Medicare Advantage patients usually get hearing and dental and vision and some other benefits, and they get it for roughly about the same price as what a fee-for-service beneficiary would get for less than that amount of benefits. So this is a very popular program. They also market directly to the end user, as opposed to marketing, through, say, I don't know, your employee benefits manager or some other third party. And it has been growing at a very healthy clip, and is now topped 40% of the Medicare program, and is cruising towards, in not too long, being 1 out of every 2 Medicare beneficiaries are in a private plan. Medicaid got there first. Part of the reason that Medicaid got there first was because states, if I haven't imparted any message to you, the one that you should take away is that by design, it's very difficult to do something in Washington. Nobody wants DC to really be able to do something big and transformative and ambitious. So the city was kind of designed so that you couldn't do that. States have a lot more authority. What states have even more than that, though, is they have, in almost every case, states have a balanced budget requirement. So when a state has a revenue downturn or a recession of any depth, they have to bring their budget into balance anyways. And what most states have done over the last 15 years is, if you go back a few recessions, they've started shifting management of a Medicaid program out of direct management from, kind of the Medicaid division in the health department to private managed care contractors. So, now we're at roughly about 80% or more, in some cases 100%, like say Texas, Medicaid lives are 100% managed by private contractors. So this is good, because obviously they're faster on the draw. They usually tend to be faster on detecting waste, fraud, and abuse, and they're also faster on kind of analyzing their own data. Now, back in the late 80s, early 90s, managed care obviously was the bogeyman of every healthcare debate. They were, evil, heartless entities that just denied care. They've all evolved. Their managed care definitely tries to control utilization But they do it very differently now. You know, they do things like step therapy. So they want you to try like lower cost alternatives to something really expensive, and then kind of move you up there. Or they, you know, try to encourage their providers to use things that are, you know, like move to generic drugs, or, you know, try to get some sort of savings on commoditized devices. But, you know, flat out denying care is something that plans usually recognize as something that's very politically unpalatable. So they try to focus on cost control through a lot of other levers that they can pull. Payers have consolidated a lot, so they're much bigger than they used to be. And that in many markets has given them more leverage over hospitals who are much more highly consolidated. I mentioned telehealth has gone up. Managed care authorized a lot of telehealth visits during COVID. That's starting to come down now, but you know, again, places like telebehavioral, it's going to be an enduring change. I'm going to move through this pretty fast because I think we've gone through our required time. But you know, again, if you look at areas where they're kind of focused on both, you know, reforming care, not just to save money, but just kind of reform care to get better outcomes, you know, you're definitely seeing more of a focus on different physician specialties, on behavioral, obviously on drug spending. All their employer partners are very much about trying to keep their drug inflation down. And also on the lab industry, you know, especially in places like toxicology, you just, you know, there was a lot of docs billing a lot of lab tests that maybe were questionable as to their medical necessity. We talked about value-based care being a catch-all, hard to pin down term at the federal level. Not surprisingly, that's also true down at the commercial managed care level. So, you know, again, everybody's trying to find good network partners and come up with a good, you know, kind of a proto or full capitated arrangement for different care models. But I think it's best to say that we're on the cusp of rolling more of that out, but we've got a ways to go. It's a big learning exercise, both, you know, in terms of what works, and it's also you know, a slow crawling exercise because you've got to, you know, train providers and get them used to the idea. All right, we made it.
Well, thank
Isn't
you,
that
Brian.
amazing? You all get your CEP credit because we hit that marker.
Yes, we did. Thank you very much, Brian. Really interesting info. I'm sure it was informative to our attendees. You gave us a perspective that you know, we don't get very often. But thanks to everyone that attended. We are going to skip the Q&A since we have used our allotted time. Be on the lookout, everyone, for our next event, which will be in 2022, and we look for it to be in person. I know everybody will like that. So with that, I'm just going to wish everyone a good evening. And again, thanks for attending. Thanks, Brian.
Thanks, everybody. Appreciate
Thank
the time.
Thank you.
Great, thank you. Thank you for the invite. I enjoyed this.
Thanks so much to all of our guests. Everybody have a great evening, and we'll see you next time.
All right, bye.
Bye.